So welcome to our audience today. You're here at the Lunch, Learn, Link seminar series. And we're getting close to the end of our academic year, but we have a special speaker today, Dr. Tony Alberg. And he, may I ask everyone on the call to mute their speakers, their microphones? Thank you so much. So Tony Alberg is a familiar face to many of us at Hopkins. I remember working with Tony back in the 2000s, early 2000s, and I think we met even before then. So it's wonderful to see him again. He's moved to the University of South Carolina in Columbia and is now professor and chair of the Department of Epidemiology and Biostatistics. But the reason I've invited him to come to our seminar series today is he's my go-to person for skin cancer epidemiology. And for those of you who are following this topic, you know that there's still changes afoot in the incidence and mortality statistics. So I'm really pleased to have Tony here to give us a big picture of skin cancer. Thanks, Tony.
Thank you, Norma, and thank you so much for the invitation. It's an honor to have the opportunity to be here, and thank you all for joining today. I really appreciate it. And so what we're going to do is take a very high level look at skin cancer from the public health viewpoint, really. So the goal for this time together, and I don't know how these sessions usually run, but if you have questions, I'm fine with just taking them. Unmute yourself and to speak up if you'd like. I'm unable to view the chat, so maybe Norma could moderate that as well. So really what I'm hoping to do is just highlight the fact that skin cancer is a major public health problem. It really doesn't get talked about enough. And so just to help educate you all, if you're not familiar, for the scope of the problem, and that there is a way forward out of this. And even though it's a big problem, it's theoretically largely preventable, in need of public health action. So this is the outline I'll follow. Skin cancer, the term is used to refer to different things. So I'll just define terms and then give a brief background, describe why it's important to public health, and then look at the way forward for what the solutions may be. And at the end, turn to the issue of climate change, the leading issue for society at large, and it also has impacts for skin cancer prevention. So when I use the term skin cancer in general for purposes of this talk, I'm going to be referring to specific types of skin cancer, and that will be cutaneous melanoma or melanoma of the skin, and then keratinocyte carcinoma, which has also in the past been referred to as non-melanoma skin cancer. And you'll still see that referenced on some of the slides I'll present because some studies just measured non-melanoma skin cancer. And then there's two major histologic types that comprise keratinocyte carcinoma. Those are basal cell and squamous cell carcinoma of the skin. And so just to know, there are other forms of skin cancer, but they're not the focus for today. And they're much more minor as a public health problem. And so if we just took a look at melanoma and keratinocyte carcinoma, just to get the lay of the land and context for what's going on. Melanoma is much rarer, so a much lower incidence than keratinocyte carcinoma, which, as you'll see, is by far the most common form of human skin cancer. The invasiveness, the probability of metastasis is much higher for melanoma than it is for keratinocyte carcinoma, which is very low. And that's part of the reason why you rarely hear it mentioned, really, when we talk about cancer. The mortality rate, therefore, because of that higher invasiveness of melanoma, is much higher for melanoma than it is for keratinocyte carcinoma. And then there's also interesting distinctions just for who treats the predominant number of these patients. Melanoma would be treated in oncology practices by and large, whereas keratinocyte carcinoma would usually be treated by dermatologists. And so why are we interested in this problem, and why was Dr. Kanarak interested in this as a topic? And you begin to see why here. So most cancers now, this is really an amazing time for cancer prevention, cancer control, and cancer treatment in general, where we're seeing really great decreases in cancer mortality due to major investments in primary and secondary prevention, as well as in advances in treatments. And that's what makes these trends shown here for men in the top in gold and women below in the darker color for the incidence trends in melanoma from 1975 to 2017 in the United States. And you see strong upward trends and a tripling in the incidence of melanoma over time. And some of this is thought to be attributed to greater detection and so on. But even that and other alternative explanations can't get around the fact that there's really a genuine and large increase in the occurrence of melanoma. And just to look at it in another way, this is a chart I thought was interesting from the National Cancer Institute that's just limiting to the cancers that have shown any hint of increasing trends in the recent past. And you can see here that even when we limit the comparison to those cancers with increases, that the melanoma has been consistent and has increased far more than any other cancer. So from these kinds of data, it's a safe inference to say that melanoma is a large and growing public health problem. The incidence has been rapidly increasing. Estimates for this year in the US are about 100,000 cases and 7,600 deaths. The survival for melanoma compared to other cancers is quite good overall, 93%. But with advanced stage at diagnosis, it's much poorer than that. And so now shifting to keratinocyte carcinoma, and the two major histologic types then, basal cell carcinoma, which I'll refer to as BCC, and squamous cell carcinoma as SCC. And the originating cells for these are clearly the basal cells for basal cell carcinoma and squamous skin cells for squamous cell carcinoma. Basal cell carcinoma doesn't have any premalignant form, whereas for SCC, actinic keratinosis is a precursor lesion of actual cancer. In terms of the percentage of all keratinocyte carcinomas, basal cell carcinoma is the most common by itself, the most common form of human cancer, and outnumbers squamous cell carcinoma in most populations by at least 4 to 1, sometimes 5 to 1. And then in terms of invasiveness of these cancers, basal cell carcinoma is the risk of metastasizing and progressing is almost 0, but I put less than 1% just to be on the safe side, and about 3% for squamous cell carcinoma. So the deaths from keratinocyte carcinoma overall are coming from SCC. And then in the United States, we have no surveillance program for keratinocyte carcinoma, partly because it's so common. The burden is so high, it would take a major investment for cancer registries to actually be able to count them. And they're so common, it's difficult to count. And so in recent times, we've only relied on analyses of claims data to estimate the keratinocyte carcinoma burden in population. So here's one of the go-to publications for these estimates. So this is based on claims data and an algorithm that's been used. This report focused on 2012, but they also updated their prior published report from 2006. And you can see here now, if we look at the cases, 2006, about 2.5 million cases, 2012, about 3.3 million cases. So number one, these are incredibly common cancers, and the trend is going up. So these may be imprecise absolute estimates, but there's really no getting around the fact that the trend is increasing steeply, even within this narrow window of time, only a 6-year difference. And those are absolute numbers. So I just divided by the US population size for those years. And you see some decrease there in the percentage difference down to 28%. And we'd see a greater diminution in that difference if we adjusted for age. So that's kind of where we are with KC, very crude approaches, but still that wouldn't make that increase go away. And interestingly too, the average number of skin cancers treated per affected patients was 1.64. So a big point here is just whatever the true numbers are, they're very large. And to compare these estimates to all other cancers that are estimated to be diagnosed in the United States in 2022 is less than 2 million. So these numbers in 26 or 2012 are much larger than all other cancers combined. And just to take a look at another estimate that was published around that time from a different data source. So this is medical expenditure panel data that was used and actually led by a team that included someone who got their doctorate at Johns Hopkins in epidemiology, Robin Yabroff, if anybody remembers her. Again, what we see for the cases in these 5-year periods, 2006 to 2002 to 2006, 3.1 million, 2007 to 2011, 4.3 million. So again, very large absolute numbers and a very large difference, 39%. And if we do our due diligence and correct for population size, it's still a large increase. And then they took the further step of estimating that healthcare costs due to, in this case, we're referring to NMSCs because they couldn't exclude the other forms of NMSC other than in addition to KCC and BCC, but 2.7 billion increasing to 4.8 billion, a 78% difference just in this adjacent time period. So the point here is the numbers are really large, and also that the trend is really increasing quite rapidly. So if we look at keratinocyte carcinoma, also a large and growing public health problem, would be a very safe inference. It's by far the most common form of human cancer, estimate of more than 3.3 million cases in 2012, and that's 73% more than all other malignancies combined. A really rapidly increasing incidence. The number of deaths is relatively small, and again, that's partly why you don't hear about keratinocyte carcinoma very often, 2,000 deaths per year. Those would be due to squamous cell carcinoma, and then enormous economic costs. So if we combine this and look at skin cancer overall, melanoma plus KC, clearly the numbers are very large, driven by KC, and then growing larger for both melanoma and keratinocyte carcinoma. The economic costs are enormous and growing, and then it's clearly a cause of much suffering and death. Most of the deaths due to melanoma, and that's kind of a key point. Melanoma is rarer, but more fatal, and KC is extremely common and rarely fatal. So what's driving these epidemic increases in the occurrence of skin cancer? Well, I'm going to take there's very complex etiologies, and if anyone at this session has expertise in skin cancer, you'll be disappointed that I'm going to take such a cursory view, but this is really from the public health perspective, the major driver, major determinant of the occurrence of skin cancer in population. So the major cause is exposure to ultraviolet radiation. Most of that would be from a natural source of the sun, so solar UVR, and then also indoor tanning devices, tanning beds would be in the more modern era. And so that's the major cause of skin cancer, much like when we think about lung cancer, cigarette smoking would be the major cause of lung cancer. And of course, there's complex pathways that would include other factors and a lot of investment in looking at genetic susceptibility and so on. But really, the high-risk group is defined from a public health perspective or a clinical perspective by skin type. And so those at greatest risk are those with greatest propensity to sunburn upon exposure to UVR, and that ties in with fairer complexion, freckling, and red hair, and those kinds of characteristics. And so you've got the major cause of skin cancer and then a high-risk subpopulation. All of these associations are heavily dose dependent, so the risk of all skin cancers increases with greater dose and the susceptible phenotype. But the dose is also dependent on factors as well. So proximity to the equator or latitude is important, stronger UVR closer to the equator, altitude, stronger UVR at higher altitudes, and then season of the year. So stronger UVR in the summer months than in the winter months. And then it should be clear then, given the high-risk phenotype, that this is most relevant to people of European ancestry, that white people are the highest risk group. But this is an era when, and we've been in an era for a long time where we need to pay close attention to issues around structural racism and health inequities. And still, even with skin cancer, there are inequities and health disparities concerns. So compared with white people, people of color have a much lower skin cancer risk because it's all tied to skin color, actually. So the greater the amount of melanin, the lower the risk of skin cancer. But very importantly, the risk is not zero. And that's a fact that's often underappreciated and may in part lead to lack of worry about skin cancer in people of color. So tied to this, then, people of color tend to be diagnosed with later stage disease and have worse survival. For melanoma, the data is strongest there. So that's an issue that needs to be addressed. And so given this shared major etiologic pathway of ultraviolet radiation exposure driving skin cancer occurrence, we would expect that there would be co-occurrence of keratinocyte carcinoma and melanoma in high-risk individuals, given those circumstances. So a report from way back now using CLUE data. So this was carried out when I was at Johns Hopkins, and Jiping Chen was the first author. We observed that people with a personal history of keratinocyte carcinoma were almost 8 times greater risk of developing melanoma. More recently published meta-analysis has much lower estimates overall, but still greater than a doubling in the risk of melanoma among patients who have had either a BCC or an SCC. So all these different skin cancers co-occur in the same individuals. And so given the fact that there is a single predominant cause of skin cancer, that really gives us hope that we could take steps to prevent UVR exposure and therefore curtail the skin cancer epidemic that we're in the middle of. And so that is where we really need to distinguish. The prevention pathways will vary depending on the source of exposure. So solar ultraviolet radiation compared to artificial ultraviolet radiation exposure, and we'll be specifically focused on indoor tanning devices that emit UVR, commonly referred to as tanning beds. But there are other indoor tanning devices out there. And then both of these are rated as group 1 carcinogens by the International Agency for Research on Cancer, which means they're carcinogenic to humans. And so again, there's different pathways for each of these, as you can imagine, because it's impossible to avoid solar ultraviolet radiation, whereas artificial ultraviolet radiation is potentially more controllable. So let's just take a little look at the data relating tanning bed use to risk of skin cancer. So these are results from a recently published meta-analysis, and it's just looking at age of initiation, stratified by age of initiation, and then also stratified by keratinocyte carcinoma and melanoma. And so if we look first at just the results for keratinocyte carcinoma, we can see that regardless of the age of initiation, there's increased risk that's statistically significant, and that the risk is greater for earlier age of initiation. So that's a problem because it's young, white females in the United States that where the prevalence of tanning beds has been the highest. And if we look at melanoma, we see the same general pattern. The risks are not as high as for KC, but are large and statistically significant. So 1.47 for early age of initiation, 1.28 for later age of initiation. And again, a key point being that earlier age of initiation, stronger risk than later age of initiation. And then if we look at data for, we would expect a dose response. I've already said that based on sunlight exposure, there's clear dose response trends. We would expect a dose response for UVR exposure from indoor tanning devices. So here in this meta-analysis, they stratified by less than 10 uses per year, and greater than or equal to 10 uses per year. Ideally, you'd want to stratify more refined, but again, this is a meta-analysis based on what was presented and cut points that were possible. So what we see for KC first, just looking, we see 1.32, 1.56 for more frequent use. So the dose response relationship that we would expect to see. And then the results for melanoma are almost identical here and also show that dose response increase. So just to give you a sense of the evidence, if you had not seen it before, for why tanning beds are an important factor to consider for prevention strategies. Also, very interestingly to me, and if any of you are behavioral scientists, I think this is really interesting to think about. And if you've not picked up on it already, there's clear parallels between tobacco control and skin cancer control. And here's another factor here where tanning dependence, and there's, I wouldn't call this evidence like solid in the sense that it yet has clinical implications, but given the way it's trended, I wouldn't be surprised if that happens in the future. But that indoor tanning specifically is linked with symptoms of dependence or addiction. So associated with younger age of initiation, more frequent indoor tanning use. Interestingly and counterintuitive from a rational standpoint, individuals who are more dependent also perceive their skin cancer risk to be higher. And then it's also linked with other comorbid conditions such as depression and substance use. And I've got a few references here, and there are many more. So that's some of the evidence. And as you know, people in public health who want to prevent and control cancer, in this case, most specifically, I think it's really our duty to not sit on the evidence, but really go from evidence to action and translate that science into policy. So this is just a framework that my colleagues and I published now many years ago in the American Journal of Epidemiology related to cigarette smoking, but it applies to all the factors we study. But we start off with original research studies. We then get into our evidence synthesis, and if causal associations are made, then there's the important decision of rating the importance of that issue. So is skin cancer and UVR exposure important enough to invest in from a societal perspective to warrant public health action? Clearly, you can tell my view is yes. It's a big problem, and we either know or can find better ways for prevention. And therefore, that leads us into stage 4, the action step. So how can we protect society from the harmful exposure, in this case, UVR exposure, if the causal hypothesis is confirmed and public health action is warranted? And so that leads me into my interest in policy, led to this opportunity with the American Society of Clinical Oncology. So ASCO, for those of you who don't know, is the by far the largest organization for oncology care providers, and carries a lot of importance in terms of the whole field of cancer. The parallel group on the research side would be the American Association for Cancer Research. So I had the opportunity, just through almost pure luck in some ways, to be the chair of the Cancer Prevention Committee for this society. I believe I was or I'm sure I was the only non-oncologist that's ever served in that role. I'm a PhD epidemiologist, but part of my signature kind of focus for the year for what was going to be something that I was going to add during that year's chair was to get ASCO to weigh in on the skin cancer problem. Because if you haven't gotten the point already, skin cancer tends to be underappreciated, de-emphasized. And so despite the fact that many medical organizations and cancer organizations had weighed in on skin cancer prevention, ASCO had not. And that did lead to some challenges, I'll be honest, because a big question that everyone asked me was, well, what new are we going to add? And my answer to that was, it doesn't have to be new. Even if we reach the same conclusions that other groups, eminent groups have reached, that's okay. It's that it's coming from ASCO, and ASCO carries a lot of weight, and ASCO needs to weigh in on these issues. So then that got carried forward too in terms of the lack of focus on skin cancer. So it was assumed that this work would be published in the Journal of Clinical Oncology, which is a very high impact journal. For those of you who are familiar with it, you would know already, because that's where ASCO publishes their policy statements by and large. But very humblingly, they rejected this statement. So then it was like, okay, now we're going to go to the lower impact journal published by the American Society for Clinical Oncology, the journal JCO Oncology Practice, which is an impact factor that's up and coming, but still nowhere in the league of JCO. And then even more humbling, JCO Oncology Practice rejected it. And so then we were left with like ASCO having a policy statement that had been approved, but no ASCO publication to publish it in. And so I still remember this must have been the winter holiday season of 2019, where I spent a lot of time writing the rebuttal to the editor of JCO Oncology Practice for why it was really important to have this out there for the oncology community to refer to. And so eventually it did get published. The other thing I would note about this, it was very important to me to have representation from both the dermatology community and the oncology community, and that is the case here, so that there was ownership on both, and that it just, even though it was ASCO sponsored, it wasn't coming just from ASCO without input from dermatologic experts. So the primary prevention strategies for indoor tanning, and a lot of this is in that report, but we could break down the levels into policy level, legislative, regulatory strategies versus population and individual level education. That might be mass media that would need to be funded through generating revenue at the policy level. But at the policy level, the idea of prohibiting use specifically, but not limited to minors, is the wording we use. So clearly should be prohibited from youth accessing tanning salons, and to leave open the idea that these products could be banned overall, even for adults, even though that seems like a long shot. I think that's something from a public health perspective, we need to leave that on the table. That does remind me, I'll just give another anecdote too, because of that evidence to action does require advocacy and educating legislatures about this issue. So this was 2 years ago, almost to the day, because it was right before the shutdown for the pandemic. I was in the South Carolina State House in a committee that was considering legislation to ban indoor tanning salons, youth under 18 years of age, from using indoor tanning salons. So many states have that. I didn't have the time to look up Maryland, but I'd be surprised if they did not have that legislation already in place. And so on, being in the South, we're behind a lot of these kinds of legislation, and there's a lot of challenges, which is part of why I love being here, is to really try to make a difference. So I was testifying to a committee, and by luck, I I had just made connection with a University of South Carolina undergraduate student majoring in public health who had, during her middle and high school years, her mom used to take her and her friends routinely to tanning salons, and she was diagnosed with melanoma before she entered college. And fortunately, it was at an early stage and was resolved. But she came along to testify with me. So I thought this was great. I'll provide the evidence, scientific evidence, and then, even though that might be boring to these committee members, then here's a real life person who's been affected by this as well. And sadly, our arguments did not prevail, and I'll get turn to that again for partly why. So that got shot down in committee, never made it to a vote. Again, other policy levels are requiring improved device warning labels. So, for example, Surgeon General's warning, there's a Surgeon General's report on skin cancer. So to have those kind of warnings like we have on tobacco products, restricting marketing and advertising for use of these tanning salons. And then another avenue is financial, increased taxes, make it more expensive to the consumer and provide a hurt to the industry. So those are at the policy level. And then at the educational level, anything to prevent initiation among children and youth, and then promote cessation of usage among those who are already using these devices. So here's a key point I want to make, and again ties back to parallels with my experience in tobacco control, because that's also an area where I've been very active in research that's also pulled me into advocacy and thinking about policy. So the indoor tanning industry profits by causing disease and death. That's just a fact. And so the fact that there's an industry that profits, they are going to fight to maintain their profit. So they're going to fight against these regulations with a formidable lobbying presence. So after the undergraduate student and I presented to that committee and many other public health professionals, there was a representative from the tanning industry there that laid out reasons for why tanning was good for human health and counter all the arguments and stuff. And I'm sure is providing investments in getting representatives and senators reelected and so on. And that carries a lot of sway. The industry also invests in publishing letters to the editor that criticizes research demonstrating the harms of ultraviolet radiation exposure. So I became aware of this because of my own research, and then getting letters to the editor saying why these results, weren't valid and so on. And then looking up, it was the same person over and over, and they were tied. It was very cleverly hidden, but all their funding tied back to some sort of foundation that had electric. Anytime you see electric in the title of a funding source, it's going to be tanning bed industry sponsored in my experience. And then further, they invest in, I'll put in air quotes, research that shows the health benefits of UVR exposure. And what they've focused on largely, and some of you who work in vitamin D may not like this, but they really leverage the findings that vitamin D has health benefits, and the fact that solar ultraviolet radiation or artificial ultraviolet radiation is the major source of synthesis of vitamin D, and to tie that into an argument for the benefits of tanning bed use. So any sort of policy initiatives and prevention initiatives has to have surveillance built in to monitor the impact of that. And so this is good news of achievements that are already being made. So these are female high school students, 2009 to 2019 in the US, and the prevalence of use of a tanning device, indoor tanning device in the past year. And we can see that during this 10-year period, there's been a decrease from 1/4, 25% of all high school female students using tanning bed devices, all the way down to more recent times, closer to 5%. So that's a real public health success, and I think provides great optimism for where we could be going in the future. And already there's some impact on a decrease in melanoma in young white females being observed, presumably as a result of this. So primary prevention strategies for solar ultraviolet radiation exposure then would follow a different path because it's not a specific product, but obviously we're all exposed to sunlight. So at the policy level, there had been rules made in some schools that sunscreen products couldn't be brought in without a physician approval. So treating it like a medication rather than a readily accessible product that students would benefit from using when they're outside during the day and so on. So that's part of the ASCO report there. Support development of improved sunscreen products would yield benefits. And at the policy level, improving access to the built environment, to shade structures and other infrastructure improvements to minimize exposure. So this would be important too if we think of youth on their playgrounds and so on, that there's access to shade available to them when they're outdoors. And then the population and individual level education. The message would be to promote sun avoidance and when in the sun. And that's clearly not possible for all people. Some people work outside for their jobs and so on. So for them, it's not always a choice, and it's not a choice for them. But when in the sun, use sunscreen, skin protective clothing, hats, and sunglasses. Definitely education to prevent intentional sun exposure for vitamin D, and social marketing to promote the acceptance of and positive regard for untanned skin. So that's kind of an underlying problem that we have, is that the media in general has promoted the idea that tan skin is really a healthy and desirable endpoint, when in fact that's not the case, particularly for fair-skinned people that are at the highest risk for skin cancer. And then also we concluded in our policy statement the need to invest in research to define effective skin cancer prevention interventions, best practices, with a clear focus on dissemination and implementation and the avenues through educational institutions. This is really important for clinical services and then also public policy messaging. And then also the need to develop evidence-based approaches for public health programs that are aimed at populations that haven't traditionally been targeted by skin cancer prevention. So, for example, sexual minority men in particular have high rates of sunburn prevalence and resulting skin cancer, and then focus on also low SES populations. And as I mentioned before, very important to message to persons of color. I'd like to just for a minute say how important the role of clinical providers are. That's important with any kind of preventive interventions, including smoking prevention and cessation. Same here, discussing skin cancer prevention with patients. The importance, the messaging of kind of the key messaging. Pediatric care providers are particularly important to prevent that sun exposure in early life. Again, UVR exposure is dose dependent over a lifetime. That's most clearly illustrated for squamous cell carcinoma, but is present also for basal cell carcinoma and melanoma. And then we also, for the first time, highlighted the importance of oncology providers to integrate skin cancer prevention into survivorship care planning. And at this point, I'm just going to turn to a completely different topic and just talk about the future. So that's based on kind of the notion so far, but there really hasn't been enough integration into the public health thinking about skin cancer prevention to account for climate change, which is, of course, the leading societal issue of our time, as well as leading health issue for the future of humankind. And so when we think of climate change and skin cancer and the impacts it can have, one pathway is through stratospheric ozone depletion. So ozone depletion increases UVR exposure at the Earth's surface, and that increased UVR exposure leads to increases in skin cancer risk then. So there's been statistical models done looking at this, just modeling what could be anticipated for a 1% decrease in this example in ozone layer thickness. And you can see from these estimates that they're quite pronounced. For each 1% decrease, really high increases in squamous cell carcinoma, basal cell carcinoma, and melanoma. And it's in these order of the dose dependence is clearest for squamous cell carcinoma, which is why the greatest impacts would be seen there. So that's a scary thought to think about. Also consider this would not be distributed equally. So say people with dark skin near the equator, such as in Africa, would not feel these impacts to the extent that fair-skinned people near the equator would be, like immigrants from the UK to Australia and New Zealand, which already have large skin cancer problems and would be exacerbated there, as we would have in North America as well. And then another impact of climate change, the increased ambient temperatures will impact the occurrence of skin cancer too. So it's underappreciated the fact that hotter temperatures interact synergistically with UVR exposure to increase skin cancer risk. The underlying mechanisms for that are not well understood, but that's been seen in laboratory studies and animal models, as well as in modeling data in human populations, that even with UVR exposure, adding temperature to the model is a significant predictor. Also, heat would impact human behavior, so it'd give more time for outdoors and therefore increased UVR exposure through that separate mechanism. And there's also been statistical models done to model the increase of temperature change. And so an example of a more recently published model, this work has been being done for many years now, but what we have here is for each increase in temperature, we'll just focus to start on a 1 degree centigrade increase in temperature change, and what impact would that have on keratinocyte carcinoma by 2100. And we see a 6% increase in squamous cell carcinoma and a 2.8% increase in basal cell carcinoma, with a 1% increase in temperature change. That would be the optimistic scenario. And then you see the dose response relationship there of the increase with more pessimistic scenarios. So this is obviously an important topic to consider. So just in summary, I look forward to any questions or comments you have, but skin cancer is a major public health problem. It's a big problem, and it's growing. The fact there is a single predominant cause opens up pathways for prevention, and we can curtail this epidemic with societal investment, but it will take a long-term sustained societal commitment. And that includes, for many other reasons other than skin cancer, but including skin cancer, the need to combat climate change. So again, I'm really appreciative of this opportunity. Thank you for taking time out of your busy days to attend, and I look forward to any questions or comments that you have.
In the Zoom world, we have two hands clapping. Thank you so much, Tony. This is really a thorough review of risk factors for skin cancers and even the types and of cancer, and the differences in magnitude. I don't see any questions in the chat yet, but folks, we're a small enough group. You can your mute
raise my
off.
real hand.
Yes. Okay.
Tony, I really enjoyed your talk, and I learned a lot from you. Two quick questions. Is there any genetic susceptibility that is associated with either one of the two cancers that you described? And then we always are confused about the SPF on tanning lotions. What do you think about that?
Okay, great. Both really good questions. So genome-wide association studies have been done, as well as more focused genetic epidemiology studies to identify high-risk variants. I think what's interesting about those, and again, it's another parallel with my experience with tobacco and lung cancer, where you saw the major hits being in genes that were associated with nicotine addiction. For skin cancer, the major hits have tended to come in variants that are in genes that are determinants of skin color, of melanin concentrations, of red hair color, of freckling, for example. So there are findings, and it goes beyond that. And I am not prepared to answer a more in-depth question, but I think in general, the major findings have been to reinforce the importance of the phenotype and finding genetic characteristics associated with that high-risk skin cancer phenotype. So, and others may have greater expertise and like to comment. That is interesting about the sun protection factor too. So I think the general advice is the higher the SPF, the better off you are. So again, there's no shame in having an SPF that's, very high, even in the triple digits. I've seen them occasionally, but I think where is confusion too is the quality of the evidence supporting those FPF ratings and the need for the FDA to be more stringent and clearer about how those products are tested, just as you would see, say, for nutritional ratings and so on, of what they can claim, that those get greater scrutiny and those standards for those ratings become higher.
Thank you very much, Tony.
Thanks for the questions.
Other questions? Tony, I'll ask you one. You mentioned that people go out into the sun to increase their vitamin D. What is the affirmative message about that we should be giving people? Is 5 minutes a day okay enough, or are sunglasses, going out with sunglasses and tanning lotion on, is that enough? How should we fine tune that message?
Yeah, I'm really glad you asked that question. So again, you know me well enough over the long term, but I would come down strictly like that. There is a clear message. You don't need to go in the sun to get vitamin D. We have vitamin D supplements, and feel free to use those. Those can be used at relatively high doses and still be quite safe and be good for bone health and all that. But that's an area where supplementation really is the answer that I would give. The idea of going out with sunscreen on, the idea of sunscreen is to protect from the exposure. And so that would be inefficient to and hamper the vitamin D synthesis. So I think the clearer the message on that, like when we're dealing with the public, clarity of messaging is important, that you just don't need to go in the sun at all for your vitamin D. And of course, that's not going to be well received. But I think that's the messaging we need to give. And then, it's the hedging. Well, if you need to, then that. But in terms of broad scale media, I would not even include going into the sun for vitamin D synthesis. So
do you have a sense of where physicians are on that advice? Because they might want to track vitamin D levels, for instance, in individuals.
Good question. And that's a really good question. I've not seen a study on that. That would be a really interesting study. So I'm making a note of that to know what the messaging is from primary care providers, because that could be huge. And their message should be supplements, but whether or not that's the reality, I do not know.
Yeah, because I think, there's growing opinion that vitamin D, of course, is important. And if there are, if the doctor tracks it, it gives the appearance too that it's a very important indicator, and that it can be taken care of, and there's a
Right.
conversation too.
Right. And following through on that medical model, it might be, yeah, this is important. I'm going to track it. And by the way, here's your medicine that you take for it. Your medicine is a vitamin D supplement. So take this every day.
Right. Well, I remember years ago, there was an article about, the public health pill, and it had 7 supplements in it, including aspirin. So maybe we'll go back to something like that.
Maybe that sounds complicated, but vitamin D is pretty simple. I think it's pretty
Right.
straightforward.
Tony,
Yes. This is Olivia Stanford. Or sorry, excuse me.
go ahead, Olivia.
I had a quick question. I was just wondering, has there been any evidence of smaller UV devices like those used in beauty spas and things contributing to skin cancer? I know, for example, certain types of, I know I have a nail machine at home that emits a UV light, and it lasts longer, but I use it, maybe twice a month. And then that is direct exposure to my hands and fingers. So I was wondering if there's been any evidence with those kind of devices.
Thank you for the question, Olivia. And the audio wasn't good for a key word you said. So the question is about indoor devices and what specific type?
The kind that they use in beauty spas. So for like certain types of nails or facial treatments, they'll use a UV light directly on the skin. They have some that are just for the hands or the feet only, but I know you use that more often than maybe the full body ones, depending on the person.
That's a great question then. And the answer, I think that if you were present for the entire talk, you would know the answer in your heart. The answer is yes, there would be risk. If they're emitting ultraviolet radiation, that's going to increase the risk of skin cancer. Any exposure is going to increase the risk. And that's where it gets to be a balance. There's also phototherapies and so on where patients are treated with ultraviolet radiation that have been well documented over the decades to lead to increased skin cancer risk. And the question then is, in those situations, is the balance of risk and benefit. So for example, in the situation of women in a beauty salon, or any person in a beauty salon, I should say, then, is it worth it for that limited low exposure to a specific anatomic site has enough benefit that, it outweighs the skin cancer risks. And I would think what would factor into people's minds would be their skin type. So if they're a very dark-skinned individual, that would be, I think, a decision that would make it easier to tolerate compared to, say, the very fair skin, high propensity to burn, red hair, freckle phenotype that, you'd want to think twice.
All right,
Thanks,
thank
Tony.
you.
You're welcome.
Elizabeth Platt sends a note in the chat. Tony, great to hear your story, including working with ASCO for guidelines. Epidemiologists participating in and leading guidelines and policymaking is critical for ensuring population-focused strategies. What voices are needed to try to compel capturing skin cancer diagnoses by registries? I understand the burden on the reporting facilities. And you probably know Elizabeth's been involved in cancer, but she's also chair of the Cancer Registry Advisory Committee for the Maryland Registry.
That's great. And Norma, I didn't hear, who's that comment from?
Elizabeth Platts.
Oh, terrific. Yeah, so glad, Elizabeth, to hear from you. So great questions. And I think that is a major lift, like to make that kind of, it would need to be a federal investment to say that keratinocyte carcinoma is a big enough problem that we're going to invest in going out and collecting the data, or at least doing special surveys. The NCI back in the early 1970s did a special survey to estimate the prevalence, and even that has proven to be of tremendous value for these kinds of modelings for the health effects of climate change and so on. So that would be a really hard lift. I think that would need a lot of impetus from a lot of major organizations to get that done. And that, again, I love the question, because that's not to say it couldn't be done. It's just not been on the radar screen to emphasize the importance, the value of it, and that the benefits would outweigh that, would be well worth the investment. So I love the question, but it would need like organizations like ASCO, like AACR, major organizations from a variety of public health constituencies, APHA and on down the line, as well as us as individuals to make our voices heard in a meaningful way.
So Tony, Elizabeth has a follow-up question. Would an automatic report from pathology labs work? You know, we do that for prostate cancer.
Great question. So I love that question, Elizabeth. So that's really great because that's taking advantage, instead of thinking of cancer registries in the old way, of how for a modest investment, we might be able to make this happen using the great advances in data science and so on. And I love that idea. That could be done because that's what's being done in these analyses of claims data to get the estimates. And if we were just routinely investing in reporting those to a repository where those data were being cleaned and develop refined algorithms, that could provide part of the answer that we're desperately seeking. So I love the thinking, and that's a way to do it much less expensively, but still get real data that would be meaningful and real time, relatively real time data that we need to track these trends.
Yeah, the real time is always a challenge. Is a challenge also. So Nicole Hughes actually inserted a URL and lets us know that workers are affected as well. And I'm supposing that these are workers in a salon, for instance, would be affected by the UV radiation. Tony, another question sort of related to the genetics. I thought some time ago I saw an article that individuals who had been diagnosed with a skin cancer had a higher risk for cancer of another site. Has that developed into a risk profile item?
Yes. So I'm sorry, I don't know what you're seeing now, but if you can, I was getting into the chat and hit the wrong button. So if what you see is chats, I apologize. But that's actually been, I did not put that into this talk, but that's an area of research that I have a great interest in myself. And so exactly. So skin cancers, whether it's melanoma, and my research has focused more on keratinocyte carcinoma, is clearly a marker of increased risk for cancers not on the skin. So I think that's another concern. The reason I've been thinking that is a topic that needs to be more widely known is, again, because skin cancer tends to be so de-emphasized and underappreciated, that if there was greater appreciation that it's a marker of increased risk for other cancers. And it's the interesting thing scientifically about that too is it's not limited to one or a few types of cancers. It's across the board increases, some greater than others, but you know, you're talking colorectal cancer, lung cancer, breast cancer, the big four, hematic malignancies increased as well. So there's a very strong, and that body of evidence has grown as well, that's linking keratinocyte carcinoma as well as melanoma with internal malignancies.
Well, I think that might be a strong piece of evidence to use in arguing for increased surveillance of skin cancer.
Right.
Yeah.
So even if you aren't interested in skin cancer, you know, it's important for risk of other cancers as well. Yeah.
Yes.
And I think that's an important point that was made by Nicole too about the workers. Again, I don't have time to click on the link, but occupational exposures would be something to consider. And if that's going back to the beauty salon question, that's a valid concern.
Yeah. Well, we'll conclude for today, Tony, but so great to see you, and thank you again for your presentation. Brings us up to date on skin cancer, and of course urges us to the prevention interventions part.
Absolutely. Thank you again for the opportunity, and thank you all for coming and for your great questions and comments. Greatly appreciated.
All righty. Bye-bye.
Bye.